Hello everyone. In this video we're going to be discussing pediatric pulmonary pathologies. So whenever we identify pediatric pulmonary pathologies, it's really important to clinically correlate this because there tends to be a large amount of overlap in the radiographic findings of these pathologies. So this is a decision tree provided by kstats.com. Again, this is not a definitive rule, it's a very general outline that kind of helps us get started. For example, if you had a neonate with respiratory distress and they were premature and had small lung volume and you notice they have ground glass opacities and no effusion, you could highly consider respiratory distress syndrome. Or if you had a neonate with respiratory distress, although they're not premature and they have large lung volumes, and you notice in their history that they had a C-section or infant of a diabetic mother, and you notice bilateral opacities and pleural effusion, you could consider transient tachypnea of newborn. So again, this is a very general outline that kind of helps us get started because a lot of these radiographic appearances are very similar and tend to have an overlap, so clinical history is very important in identifying pediatric pathologies. Okay, so we're just going to go through several examples now. This patient is 31 weeks old, so they're premature, and we can refer back to the chart on the first slide that helps us guide clinical findings with the radiological findings. So this patient is 31 weeks old, presenting for respiratory distress, and we know that they're premature. And then we start off by looking at the lung volumes. We identify that the lung volumes tend to be a little bit smaller over here, as we can see. And the lungs are quite hazy. We notice these diffuse opacities present bilaterally. It's pretty hazy throughout on both sides. And then we don't see any pleural effusion. The costophrenic angles are visible appropriately on both sides. So if we were to follow the chart in the first slide, this would likely classify as a respiratory distress syndrome because this patient is premature. The lung volumes are a little bit smaller than what we would expect. There's bilateral hazy opacities in both sides, and there's no pleural effusion as far as we can see. So yeah, this patient is presenting for respiratory distress syndrome. Okay, this is another example, and this patient is similarly a premature patient presenting with respiratory distress. So we start off by identifying the lung volumes, which we notice are quite small, similar to what we saw in the last one. We don't notice any signs of pneumothorax, which would show hyperlucency on the edges. We don't see that anywhere. It's very diffuse, kind of hard to see. So there's hazy bilateral pulmonary opacities, and we don't see any pleural effusion anywhere, which we would notice at the bottom next to the costophrenic angles. We don't see that anywhere. We notice that the patient is intubated. So again, this is a respiratory distress syndrome because we have bilateral hazy opacities, no signs of pleural effusion, and a small lung volume. And again, they're premature, presenting with respiratory distress. Okay, so this is another example. This is a patient with having respiratory distress born at term. And we start off by looking at the lungs, and we notice how they're a little hyperinflated. So they're a little larger than what we would expect bilaterally. We also notice it's quite hazy, so ground glass opacities are present throughout both lobes of the lungs bilaterally. We don't notice any pneumothoraces around the edges. We notice how the costophrenic angles appear to be a little harder to see. So this could be a small bilateral pleural effusion on either side. And so following this chart, this would likely lead us to a not premature infant with large lung volumes, maybe a pleural effusion and diffuse opacities bilaterally. So this would mean it's a transient tachypnea of newborn. And again, these are just very general outline. These are not definitive rules. It's just kind of to help us get started. This is another case. The patient was born at term, and we start off by looking at the lung volumes, and they appear to be pretty normal. We don't see any pneumothoraces on either side. The lungs are still a little bit hazy, and we notice pulmonary opacities that are present throughout, although they're not as bad as the last one. And we can kind of make out the costophrenic angles on both sides appropriately, so there's no pleural effusion. So this is another milder case of transient tachypnea of newborn. We don't see the severity that we saw in the previous slide. And again, you really want to correlate this clinically before you kind of give a definitive radiological diagnosis. Okay, so this patient is presenting with respiratory distress and is born at term. We start off by identifying the lung volumes, which appear to be normal or maybe a little hyperinflated. It's pretty hazy bilaterally. There's coarse opacities that are present. They're a little less homogeneous than what we previously saw. We can clearly make out the costophrenic angles. There's no signs of pleural effusion, no signs of any pneumothoraces bilaterally. So this is an example of a meconium aspiration. And again, this might seem similar to transient tachypnea of newborn, although that's why it is really important to look at the clinical scenario before, especially for test questions, because the clinical scenario can really help us hone down the radiological findings and help us answer the question. Okay, so this patient is presenting with respiratory distress and is born at term. We start off by identifying the lung volumes, which appeared to be pretty normal, maybe a little hyperinflated. It's pretty hazy bilaterally, more so on the right side. We see the coarse opacities that are present throughout the lobe on the right side. We don't see any pneumothoraces on either side. We can make out the costophrenic angles. There's no signs of pleural effusion. So this is an example of meconium aspiration. And again, you really want to correlate the clinical findings with the radiological findings because this can get really confusing sometimes. Okay, so this patient is presenting with respiratory distress and is born at term. We start by identifying the lung volumes, which appeared to be normal. It's pretty hazy bilaterally. We kind of see these patchy pulmonary opacities over here and over here. We don't notice any pneumothoraces on either side. And we can see the costophrenic angle here. It's a little hard to make out here. This could be indicative of a pleural effusion on the left side. So this is an example of pneumonia, and pneumonia tends to have a very variable expression. So again, it's really important to look at the clinical findings. Okay, so this patient born at term presented with respiratory distress. Start by identifying the lung volume, which appears to be normal on both sides. We notice this area of hyperlucency over here. This is likely indicative of a pneumothorax. We don't see that on this side, so right-sided pneumothorax. Pretty hazy appearance, diffuse pulmonary opacities bilaterally, which we can see over here. No signs of pleural effusion anywhere. Costophrenic angles are visible clearly. So this is an example of a pneumonia. And again, pneumonia can have very variable presentation. Okay, so this might be a little different than the previous pathologies that we discussed, but I thought it fit well in this video because this is a very high yield concept that tends to be tested regularly. So this is a 1-year-old patient presenting with respiratory distress, and we start off by looking at the upright x-ray that they got, and we kind of notice how this side is a little more hyperinflated than this side. So there's a left hyperinflation compared to the right. We don't notice any pneumothoraces on either side. We don't notice any pleural effusion. Everything else appears to be pretty okay. So whenever there's asymmetrical inflation of the lungs, obtaining lateral decubitus view of the chest tends to be the next good step in order to identify a central airway obstruction. So whenever you see this, you should think of a central airway obstruction. And so then they got these two images. This is in the right decubitus view. And what we see here is the right lung partially collapsing because it's down due to the gravity and the mediastinum compressing on it. So this is normal. And then this was in the left decubitus view, so the left side is downwards. And what we notice is the air trapping is preventing the lung from partially collapsing that we saw over here. So this means there's a foreign body obstruction in the left lobe of the lung, which is preventing its collapse. So that's why the lung was asymmetrically hyperinflated and it did not collapse as it should have as compared to the right side. So thank you guys for watching this video, and I hope it was helpful.